Okay, Dr. Kenneth, are you there?
Yes, I am.
Okay.
Mhm. Um, mhm. A 24-year-old previously healthy woman is evaluated for skin rash, joint pains, and renal failure with C3 and C4 levels and a normal factor level. Which of the following most likely triggered the complement system activities? It has reduced C3 and C4. I don't know if we've done this. I probably missed class.
Hello, you said what,
Um,
Dr. Kenneth?
I don't know if we've done C3, C4. Maybe it was yesterday. I missed it. I wasn't
Oh,
there.
you were not there yesterday. Okay, I think it was what
No.
he did yesterday. Yeah, it was what he did. Don't worry. Let me
Oh,
let me let me skip it then. Let me call another
all
person.
right.
Okay, so you
All right.
just try to pay attention. So let me call Dr. Paulette. Were you in the class yesterday?
Yes, I was.
Okay, you can just try.
Okay. A 24-year-old previously healthy woman is evaluated for skin rash, joint pains, and renal failure. She is found to have decreased C3 and C4 levels and a normal B level. Which of the following is most likely triggered the complement system activation in this patient? I think the answer we chose yesterday was E.
Okay, so we've done
Yeah,
this particular question. Okay,
yeah, we did it in class.
yeah. So why are you picking he?
I think because the classic pathway is activated also.
Okay,
Yeah.
yeah. So why do you think the classic pathway is activated?
Hmm.
Okay, so the reason why the classical pathway is most likely activated here is that you are having a reduction in the level of C4 and C3. C3 is actually common to all the pathways. You know that C3 will be formed by almost all of them. They form the C3b. But
Yeah.
if you remember, the classical pathway starts from C1. So your C1 will cleave the C4 into C4A and B. Then it will also cleave C2 into C2A and B. So the C4 and the
Yeah.
C2, the C4B and the C3B will form the C3 convertase that will go ahead to also cleave C3 into C3A and C3B. So C3, C4, C4B, C2B with C3B, that's like C5 convertase. So that will drive it towards the last one, which is our membrane attack complex containing C5, C6, C7, C8, and C9. Now, one thing about those pathways that anyone you're activating, you get it get consumed at the end of the day. So because we are seeing that C4 is getting reduced and our C3 is getting reduced, it means that you are most likely activating that classical pathway. Now, you can also tell me that why not the Manus binding lecithin pathway you get, but that's why you have to consider the presentation. So skin rash, joint pain, renal failure. What do you think this is likely talking about in terms of diagnosis? Skin rash.
Manigos.
Hello? You said what? Sorry, it's raining at my side. I don't know if I heard you well. Dr. Paulette, what did you say? Hello?
I'm saying to skin rash, joint pain, renal failure, is it SME?
So in a very young woman, what do you think? Yeah, so that's SLE, Abby, Dr. Pauline.
Then
Hello? Hello, can you guys hear me?
yes.
Okay, so that's SLE. So SLE, involve formation of those immune complexes. So so that's the way it works. So that's the reason why you are picking IgE antibody complex formation, because that is what will activate the C1. C1 will go to activate C4 and C2, cleaving them into C4b, C2b. That will join together to form C3 convertase. So C3 convertase will also split the C3 into C3a, C3b. So and the reaction continues like that. Okay. Um, so Dr. Mumina, Dr. Miriam there, Dr. Miriam, are you there?
Evening.
Okay. Okay, Dr. Miriam.
Hello.
Yeah, I can hear you.
I think said Dr. Miriam, or is it me you were calling?
Dr. Muminat, Abi. Okay, so Dr. Muminat, over to you.
Oh, okay. 72-year facility due to fever. The patient has a history of that mellitus, ischemic stroke, and neurogenic bladder. She has an urinary catheter. Temperature is 38.8. Blood pressure is 80/40. Pulse is 130 per minute. The patient is lethargic and disoriented. Extremities are her breathing. Lungs are clear on auscultation and there are no heart murmurs. There is left coastal vertebral angle tenderness. The urine in her catheter appears cloudy. Her leukocyte count is elevated with left shift, and urinalysis shows pyuria and bacteriuria. Chemical mediators is most responsive to current condition. Okay.
Okay. So just look at the history. What's your diagnosis from the history? If you can put a diagnosis to this, that can help you. Hypotension, you know, bacterial, pyuria.
No, as in the beginning of the like the let me scroll see the beginning of the question.
Yeah, I've scrolled. Maybe it's my network. It's already at the beginning. I think it's my network. There's a lag.
Okay. All right. Okay. So okay. So I think she's having temperature, fever. So she's having some kind of inflammation going on.
Okay.
So plus infection. She has infection, obviously.
Mm-hmm.
So it's definitely. I don't think it's interleukin 3. We did it yesterday, but I can't really remember. But if I just want to say answer from what I think should be
Okay. So I'm trying to show you all the options.
for now, I'll go for Tumonekwa.
Dr. Muminat, what did you say?
Yeah. So I said I will go for F. I'm
Okay.
just guessing.
Oh,
We
yeah.
did it yesterday, but
Okay,
I
it's
can't
fine. It's
really
fine. No problem, Dr. Muminat. So,
answer.
so we'll say it again. So, the diagnosis here is actually sepsis. So why? There's a fever. Look at the temperature, 38.8. There's hypotension, 80/40, and you have tachycardia. The pulse is 130. Most likely in an infectious setting. So somebody is having an infection, most likely a urinary tract infection from the history, um, and also the fact that the urine is cloudy and all those things. So the patient having pyuria, bacteriuria, cloudy urine, so that's likely to be a UTI complicated by sepsis. So because of the fever, the hypotension, and the tachycardia that we have seen. So this is sepsis. There are three cytokines that are majorly involved in causing sepsis: interleukin 1, interleukin 6, and tumor necrosis factor alpha. So your interleukin 1, it's working like TNF alpha. Both of them helps to cause the fever. They helps to recruit the white blood cells. That's why you are having leukocytosis. So you are seeing that a leukocyte count is elevated with left shift. So left shift is talking about presence of immature form of the white blood cell, because you're having a lot of them being recruited to that site. So, and it's due to the response to the interleukin 1 and the TNF alpha that is released. So you have many of those white blood cells coming around, you know. Then both of them will also facilitate adhesion to the endothelial cells, so that those white blood cells can migrate out of the blood, maybe to the tissues, depending on what is causing the inflammatory response. So you want to watch out for interleukin 1, you want to watch out for TNF alpha and interleukin 6 with respect to sepsis. So once you make diagnosis of septic shock, you are looking for interleukin 1, TNF alpha, or interleukin 6. Do you understand it, Dr. Romina?
Yes.
Okay. So whenever you see interleukin
Yes.
10,
Thank you. I do.
whenever you see interleukin 10 or transforming growth factor beta, those two guys are anti-inflammatory. They suppress inflammation. They don't like inflammation at all. Interleukin 10 and transforming growth factor beta, they are anti-inflammatory. Interleukin 3 is just to stimulate production of white blood cells or red blood cells from your no, typically white blood cells from the bone marrow, interleukin 3. Um, interleukin 4 stimulates differentiation of the antibody, like isotype switching towards the IgE and the IgG. So that's what it does. Interleukin 4 and 13 favors production of IgE. But 4 we also, in addition to stimulating IgE production, it also stimulates IgG production. So that's the explanation for the other interleukins. So don't forget that once you are making diagnosis of shock, you are looking for interleukin 1, interleukin 6, TNF alpha. Okay.
Hi, Dr. Lavali. Are we recording?
Yes, I am, Dr. Kenneth. I am. Okay.
Thank you.
So Dr. Francois, are you there?
Mm-hmm. Yeah, I'm here. Okay, it says interaction between which of the said in this patient. So, a 10-month-old boy is brought to the office due to recurrent sinopulmonary infections for the last several months. The infections were caused by encapsulated bacteria, and the patient was also recently hospitalized due to Pneumocystis jirovecii pneumonia. He was born at full term after an uneventful pregnancy. Family history is significant for a maternal uncle's end of death due to severe infection. Genetic testing of the patient reveals missense mutation of the CD40 ligand gene. Interaction between which of the following immune components is most likely impaired in this patient? Okay, if you have a missense mutation in CD40 ligand, then it's either between, that should be between activated T helper and B cells, activated T helper cells and B cells in B cell activation, or between T cells and macrophages. So let me see.
Okay. So do you remember where you find this
I
CD40
think it
ligand?
should be, yeah, it's found on the T helper cells.
Okay. So that is settled. That is settled. So where do you now see the CD40 itself, not the ligand, the CD40 receptor? Where do you see it?
So they are found on antigen presenting cells. Yeah.
Fantastic. So you have your answer already.
So there should be E. Yeah.
Yes. So, but the most common antigen presenting cell that contains this CD40 receptor is your B cell. So, because the purpose of this interaction is for what? Is for isotype switching, like class switching, so that your
B.
B cells,
Yeah.
because ideally, your B cells that is naive, that is not experienced, that is not dedicated to any antigen, the two antibody that are present on their surface is what? IgM and IgD. Mm. Those are the two. In the B cells, those immunoglobulins actually act as receptors for the B cells. So on the surface of B cells that are naive, they've not been exposed to any antigen before. They just have IgM on them and IgD. So you need to now stimulate them to produce the other ones, which is IgA, IgG, and IgE. You need to do isotype switching. The way you can do isotype switching is to interact your B cells with your T cells. And what is the mechanism of this interaction? This is not the interaction of B7 and B28 and CD28 rather. This is the interaction of CD40 ligand on your T cell and your CD40 on your B cell. So once they interact like that, it's going to activate the B cell and it's going to make it differentiate to the particular isotype of antibody that you need to differentiate into. Maybe IgA, IgG, or IgE, not IgD, not IgM. I don't know if we get what I've said.
Sorry, coming again with the immunoglobulin. You need to differentiate into A or D.
IgA, IgG, IgE. Mm? Your IgM and IgD, they're already there on your receptors, on the B cells, they are there. Mm? They are there. So when it comes to class switching, you need interaction between the CD40 ligand on your T cell and CD40 receptor on your B cell, so that that B cell will be dedicated to producing immunoglobulins of IgA class or IgG class or IgE class. That's what we call isotype switching or class switching. Do you understand it now, Dr. Pascal?
I get it.
So the reason why
Yes,
the
yes.
reason why there are just
Thank
two
you.
antigen presenting cell here is that your B cells are also antigen presenting cells. Your B cells are antigen presenting cells. Your macrophages are antigen presenting cells. Our
Mm-hmm.
dendritic cells are antigen presenting cells.
Dendritic cells.
So those guys are antigen presenting.
Yeah.
So okay. So Dr. Miriam,
Hi, good evening.
good evening, Dr. Miriam.
Which of the following science is most likely responsible for this anti-latex antibody isotype chain? A 4-year-old male is exposed to latex during a minor surgical procedure and is subsequently found to produce anti-latex IgM antibodies. Several months later, he develops anti-latex counteractive. Which of the following cytokines is most likely responsible for this anti-latex antibody isotype change?
So
Okay,
which interleukins stimulate differentiation towards Ig?
4 and
Hmm?
13. 13. The answer is D.
Exactly. So you mentioned something. I heard
Oh, did
13.
you? Okay.
I think I heard something.
Yes.
Yes, D is correct. So you said something again. Hello?
Yeah, I hear me.
I thought you were trying to shed more light on your answer. Dr. Dr. Miriam.
Kin 4 and
Okay. I think my network is very bad. Okay. So I could not hear what she was saying. Um
hello.
Yes, Dr. Miriam.
Can you hear me now?
Okay, yeah, I can hear you now.
Yes, I was saying interleukin 4 and 13.
Okay, yes. Stimulate IgE production. So that is correct. Okay. So, Dr. Uh, okay, Dr. Antonia. Dr. Antonia, are you there? Okay. Dr. Robert. Dr. Robert, do you want to try?
Myself continue to show sorry. I'm answering already.
Okay, okay.
To assess antigen presenting cell function in a clinical study, skin explants are cultured from a volunteer and analyzed for Langerhans solution and expression of which of the following surface markers is most indicative of Langerhans cell activation in this subject. Okay. B7 is a true molecule. Antigen presenting cells. CD3 is found on T cells. It's a co-stimulative signal for T cells too. Interleukin 4 receptor is more of the Th2 response. Membrane immunoglobulin and B2 microglobulin is part of MH1. So MH1s receive it's part of MH1.
Okay. Dr.
Now maturing
I'm with you.
trying to in class. I'm just trying to figure this out.
Okay. Yeah. So, of course, Langerhans is an antigen presenting cell. Abi. So,
APC cell is an APC. A marker that shows in maturation. B7?
hello.
B7? Is it B7?
Yes. So the answer is B7. So, if you remember, the first thing that happens whenever the antigen presenting cell, you know, gets attached to the protein or to the antigen is that it will want to take it to, the TFR. Yeah. So the antigen is going to be, um, it's going to bind to MHC2, you know, MHC2 on the antigen presenting cell, and the one we are looking at now is the Langerhans cells. So they are going to bind to the MHC2 or the MHC1, whatever, depending on the antigen we are looking at. But let's just say that this is an exogenous antigen now. So it binds to the MHC2 on the Langerhans cells, and your MHC2 coupled to the antigen, we try to present it to the T cell. So T cells will recognize that with the T cell receptor alongside with the CD4 or the CD8 cells, depending on the type of TMT lymphocyte that is responding to it. So that is the first thing. That is activation. That is the phase of activation. To activate them, you need to merge your MHC2 with the T cell receptor on the T lymphocyte. Then the next thing is proliferation and survival. That's when B7 now comes in. So B7 is a receptor on your antigen presenting cell, which is also known as CD80 stroke CD84 receptor, CD80 stroke CD8, coupling with the CD28 receptor on the T lymphocyte. So that's when it's now that antigen presenting cell is now mature. It has differentiated. It has even proliferated. So you know that is that. So what they are just trying to ask us here is that, do we have the receptor on the antigen presenting cell to make it a complete matured antigen presenting cell? A typical antigen presenting cells, you have your MAT2 there alongside with the B7 receptor, so that it can use the B7 to sustain the signal and proliferate and ensure survival, while the MAC2 is just to initiate the initial activation of the T cells. So a matured antigen presenting cell should have both the MAC2 and the B7 receptor. Do you get the analysis now, Dr.?
Yes, and yes, I do, because that was why I tried to eliminate all the with the elimination. That was why I was able to say,
You can
okay,
even do
this
elimination. Elimination will be very easy for you. So that is it. A typical antigen presenting cell will have your MAC2 or your MAC1, depending on what we are looking at, and the B7. The B7. B7 is also known as CD80 slash CD86. You remember that, Dr. Antonia? CD80?
Yes, I do. 88.
Okay. So, Dr. Kenne?
Yeah.
Yeah.
A 10-year-old girl is brought to the physician by her parents 30 minutes after she sustained a red ant bite to her right foot. The parents report that within 15 minutes, redness and swelling occurred at the site of the bite. Physical examination shows edema and erythema at the wound site. The action of which of the following chemical mediators on post-capillary venules is the most likely cause of these findings? They're asking about what brought about the redness and swelling. Okay, all right.
I'm not sure we've done this, but let's just try. Let's just try. I'm not sure we've done it.
No, we've not done it, but okay, maybe F, maybe F as well, since they're like signs of inflammation.
Let's look at it. Let's look at it together. So this person is having a bite from an insect. So this is likely to be what? Maybe like allergic stuff, Abby. Like anaphylaxis. Yeah.
That one.
Perhaps, yeah.
So if you are thinking that can help you with the answer. So you're now asking, which of the following mediators is responsible for the edema that you have in that kind of response? So allergic response to insect bite. What brings about the vasodilation and the increased vascular permeability? So not
isn't not the bradykinin?
Yes, that is the bradykinin. So that's why you start talking about bradykinin, histamine. Those are the inflammatory mediators that are involved in that pathway, that allergic stuff from mast cell degranulation. So bradykinin, histamine, all those things. Those are the. So Dr. Kenneth, don't worry about it. Just take this one. You said?
No, Dr. Abali, still on that question. What makes it allergic? Why isn't it just a regular inflammation?
Yeah,
because of the insect bites. That's a like. What do you mean regular inflammation? Do you mean like infection?
There's no inflammation.
There's a bite, and within 15 minutes, you start seeing redness and swelling. So that this is as an allergic reaction.
So that's
it might not be an allergic reaction because it's occurring immediately.
Yeah.
Okay. Okay, thank you, Dr. Antonio.
You say immediately. I didn't hear the last word.
So this is
That is occurring almost immediately within 15
within
minutes.
15
So it's
minutes.
an acute action.
But if it was
Yeah.
inflammation, how long would it take?
So
Sorry? It depends. Like if you go through like all those hypersensitivity reactions, insect bites and all those what do you call these things are most times the anaphylactic ones, the type ones, and they're almost immediately. So you can see the patient received the bite, and within 15 minutes started having this redness and swelling, and so there's a kind of reaction that causes release of these vasodilators, like histamine. That's usually what you see, causing that increased vascular permeability, increased exudation and everything.
Okay.
yeah.
Because an acute.
So most of the time
Okay,
when they give
thank
you a
you.
question like this, that's where they are trying to lead it into. So you'll not be really thinking of maybe from infection, because that's going to take a long time. So
A longer time.
a longer time exactly. So when you see bite from maybe an insect, you are most likely thinking of maybe a type 1 hypersensitivity or anaphylactic response. So that is it. Although we are still going to be seeing the other types when we get to hypersensitivity proper. So the one that maybe they were
Okay.
talking about you being exposed to something, maybe you are wearing rubber gloves or a metal, then we start talking about type 4 hypersensitivity from contact dermatitis. So
Mm-hmm.
that one will take some time. That one requires constant exposure. But just like Dr. Antonio have said, within that short time, you're having that inflammatory response is likely to be anaphylactic. It's an immediate type of hypersensitivity. So,
Okay.
so that is that. Okay.
All right. Okay, so a 2-year-old boy. You said I should take this.
Yes, Dr. Kenny.
A 2-year-old boy with a history of multiple hospitalizations for fever and infection undergoes immunologic evaluation. Serum CH50 assay shows inappropriately low erythrocyte lysis, and further workup confirms C8 deficiency. This patient is at increased risk for recurrent infections with which of the following pathogens?
Okay.
So this
Oh,
fever infection
yeah. This is talking about the complement again. You're not there. You're not there.
because yes, well,
Is CA deficiency. CA deficiency is similar to C9, the membrane attack. So
Yeah,
this patient will be an increased risk of Neisseria species.
exactly.
Neisseria.
So, Dr. Kenneth,
All right.
whenever you see deficiency of anything between C5 to C9, you are thinking of Neisseria. So, because you'll not be able to form membrane attack complex. That C5 to C9 forms a membrane attack complex that helps us to, puncture those Neisseria guys and lyse them. So, anybody that lacks any component of the membrane attack complex between C5 to C9 will be susceptible to Neisseria. That is it. So,
Okay. How about C1 and C?
yeah, so anybody that have the early ones, maybe between like C1 to C4, they usually have this pyogenic and respiratory tract infection. So from other encapsulated
Oh,
organisms like strep pneumo and the like. So we're also talking about
HIV.
sinusitis, otitis media, upper respiratory tract infection, and all those things. So then it's also important to note
And
that
also,
um
well,
yeah,
with the early complex, so I'm gonna add something. The C1, C2, start thinking of all those angioedema. Those
yeah.
are those ones.
So
Have
for for
angioedema.
for angioedema, what you are going to see is there will be deficiency of C4. They will already paint the history for you that this person is having, swelling of the head, the mouth, the neck. Person cannot breathe, you know, and they can even point out to the fact that there's a family history so that you know that this is likely to be a hereditary form. So they can ask you what's complement to be low in those guys. So your C4, no, it's even okay. Yeah, so they can
C1
ask
and
you, they can ask
C.
you, what's the enzyme that is deficient in them. So that's the C1 esterase inhibitor. So you don't have that control over your C1. So you are having excessive activation of your C1. C1 is converting your C2 to C2A, C2B, and it's also converting your C4 to C4A, C4B. So with increased activation of those complement, they will be consumed at the end of the day. So they will have a low value. So the one we look out for is actually the C4. So C4 becomes very low. It means it's been overactivated and it's been deposited or cleared away from the body. So that's how you can make the. I think there's a question that is actually pointing on that, so we can use that one to explain it. What I want to mention again is that for the early complement deficiency, someone that has a C3b deficiency, C3b is very important to clear immune complexes. So anybody that has a very low C3b level, they cannot clear immune complexes. So they have high tendency of developing disease that requires deposition of immune complexes, maybe like SLE, and other ones that you can think of. So that's another thing to watch out for. C3b is important in removing immune complexes from the body. Okay.
And also for encapsulated organisms too. If they lack
Yeah.
C3b, so they have increased susceptibility to infection of encapsulated organisms.
Yeah, so they helps in opsonization. Yeah, thank you, Dr. Antonia. Okay. Dr. This is the first time I'll be calling Dr. Robert. Dr. Robert.
Yeah.
Okay. So
So the main question is secretion of these antibodies most likely requires binding of which of the following. So a 26-year-old woman comes to the physician because of several days of fever, abdominal cramps, and diarrhea. She drank water from a stream 1 week ago while she was hiking in the woods. Abdominal examination shows increased bowel sounds. Stool analysis for ova and parasites shows flagellated multinucleated trophozoans. Further evaluation shows the presence of antibodies directed against the pathogen. So secretion of these antibodies most likely requires binding of which of the following. So this is a parasitic infection. So most likely you're thinking about eosinophils or eosinophils most likely. But anyway, let's look at the options. So secretion of these antibodies most likely requires binding of which of the following: CD8 to MHC1, CD40 ligand to CD40, GP120 to CD4, CD28 to B7 protein, CD8086 to CTLA4.
The issue with this question is that it's not the typical. Yeah, so I get what you are saying about the parasite like eosinophilia, yes, but this particular parasite kind of different. So even before we get to the parasite, let's look at what they are saying. They said further evaluation shows presence of antibodies. So that means that it is antibodies that interaction is actually producing.
Dr. Bobo, can I try this question? Can I try?
You said
Can I try
what?
to answer this question? Can I try to answer this question?
Wait, Doctor.
That's not the
Let
question.
Doctor what they try. So
That's okay.
Dr. Odi, so what do you think now?
Further relationship presence of antibody directed against the pathogen. So secretion of the antibodies. For I will go with CD40 ligand.
Yeah,
Because
what did you say?
I said CD40 to CD40 ligand. That's what I went with.
Yeah, so
I know
that is
that's.
very
I'm not
that
sure
is that
actually.
is very
I
correct. That is
think
very correct.
that's.
That is very correct. So actually, the diagnosis is gardiasis. So this is the gardiasis. But I know that we have not done micropara, so we might not be familiar with the diagnosis. So flagellated trophozoite causing diarrhea, that's likely to be gardiasis. And one thing that we mentioned when we were talking about gardiasis is that it's associated with deficiency of IgA. So IgA should help us take care of the Giardia infection. Someone that has enough IgA, they are not predisposed to developing that infection. So I what the body is trying to do is to interact with that Giardia antigen, to produce antibodies against it, antibodies that can take care of it. And what is the antibody that can take care of it? IgA. Now that IgA, just like we have mentioned, is not one of the primary antibodies that are present like IgM or IgD. You need to produce it through isotype switching because it's part of what we mentioned the other time, IgA, IgG, and IgE. Those ones are not, primarily present on the B cells. You need to stimulate the B cells to differentiate into them. And the way you can achieve that is to, stimulate your T cells to interact with the B cells through the CD40 ligand interaction. So your CD40 ligand on your T cells and your CD40 on your B cells will cause that B cell to differentiate into antibodies. And what is the antibodies we are looking at? IgA that can take care of this infection. So the reason why you might not want to go for eosinophils is because they mentioned that further evaluation shows presence of antibodies against that pathogen. So this is antibodies we are focusing on, not eosinophils. Do you get that, Dr. Robert?
Yes, yes, yes.
All right. Dr. Antonia, I'm sure that's what you have in mind too.
Yeah, I just wanted to explain that it's just giardiasis and what the person needs is IgA, and IgA can only be gotten from CD40, CD40 ligand.
Yeah. Okay. Um, Dr. Moravia. Dr. Moravia. Okay, I'm not sure, Dr. Moravia. Dr. Han, are you there, Dr. Han? Okay. Yes, Doctor. I don't know who is calling me now.
Sorry,
That's Doctor.
my name is Stella.
Oh, Doctor B. Well done. Nice, nice, nice one, guys. Nice.
Sorry.
Okay.
I wanted to ask that the previous question, if it was to be the regular parasitic infection, would it be
A. Well, it's possible. Actually, that A reaction is more for what's it called? Viruses and tumors.
A?
So,
And,
that's what
So what's
um
parasitic for?
parasitic will just be production of interleukin 5. So it will just be differentiation of our T cells
Okay.
towards, the
TH,
TFR2 family. So you have release of
yeah, TH,
um our interleukin, is interleukin 2 and 4 now. So interleukin 2 and 4 will now drive the naive T cells to differentiate into TFR2. So it is now TFR2 that will now release
Okay.
interleukin 4, 5, 6. So the interleukin 5 of it will now stimulate, production of eosinophils on the bone marrow. So
Nobody.
yeah,
What will make it CD28 to B7? So
that
I'm having issues on like
okay.
understanding this whole um innate and this thing. So okay,
So
the
okay,
presence of, because it was going to be like a how do I put what I'm trying to say? I thought it was going to be like an innate response from the since the body
is prepared to see. Like I thought there was no need for the T cell conversion. So I was tilting more towards A. Do you get?
Okay. Yeah. So the thing is, I might not be sure, but it's possible that the A, can but the thing about the A is that the A is only specific for viruses and tumors and all those
Okay.
endogenous molecules. But what I just want to pay attention, what I just want us to emphasize is that this CD40 ligand interaction is majorly for between your B cells and your T cells, so that your B cells can differentiate into some particular type of antibodies that we have said, A, G, E. You get? Now, the initial one.
Sorry, I didn't understand. I want to ask you about the last statement you said, between the B cell and the T cell, so that the B cells can differentiate. When the B cells encounter the organism, why do they have to go and meet the T cells? Do you get?
Okay, so this is the way it happens. This is the way, everything that is coming in, they will first be presented to the T cells, Abi now.
Yes.
Yeah. So
yes.
Now your B cell too is a form of antigen presenting cell. So
yes.
Cannot produce some other antibodies on its own, especially you know that the main function of your B cell is to produce plasma cells that produce antibodies. You know that.
Yes.
Especially if what you are looking at is something that requires an antibody response. If it's something that requires an antibody response, it needs to produce an antibody against that stuff. You get it?
Yeah.
Now, it cannot do it on its own. It needs to interact with the T cells to do it. Do you get it? It needs to interact.
Co-stimulation,
yeah, that co-stimulation is another thing. Co-stimulation is when you are talking about initial activate. The thing is, now let me now tell you something, Dr. Oluwatobi. You see that T cell that the B cell is interacting with, that T cell will have already been activated by that antigen self. You see, the antigen presenting cell that is bringing that antigen to the T cell, it will have activated that T cell. You get it?
Yes, that makes sense.
Now, the next thing is that that stuff is requiring an antibody response, Abi. And where would they get the antibody from? Where would they get the antibody from?
From the B cells.
So how would they now do it? That activated T cell will now go and interact with the B cell that is complementary to that antigen. You know that we've said it that B cell is also an antigen presenting cell. So that B cell too will have picked some part of that antigen too. So it will now try to present it to the T cell that has been activated again.
Okay.
That reaction is what we now call the CD40L. But the initial reaction, which is the initial activation of the T cell by the other antigen presenting cell, is the one that requires your MHC2 and your T cell receptor. Then the co-stimulatory signal is now your B7 on your antigen presenting cell and your CD28 on your T cell.
Okay, so everything is so there are different things occurring. The B cells see the stuff. The B cell sees the antigen and does its own. Then to now activate the T cell picks the antigen too, and then it does its own co-stimulatory blah 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 blah.
So let me just show you. Let me just show you the image so that we can just nail it. I'm trying to look for that my post-it now. That interaction is kind of
page.
I'm even trying to look for my post-it now.
You want to?
Okay, I'm coming. So where's my first stage? Jesus Christ of Nazareth. Yeah?
Dr. Babawale?
Yeah. Okay, I've seen it. Yeah, Dr. Antonio, I'm listening.
Yeah, I just wanted to, project that question again. I just want to help Dr. Toby.
Okay.
kind
You have the
of
floor. You have the floor, Dr.
just
Antonio.
simple
Very
stuff.
true, true.
Simple
You
stuff
have
on
the
that
floor.
question.
You have the floor, Dr. Antonio.
No, can I like the question? I just want to point out something on that question. Can
Okay,
you like
okay.
flag at that?
Yeah, it's here,
So,
please.
Dr. Tutu, if you can see at this question, it's yeah, you can easily be carried away looking at it as like a simple parasitic infection. But once something gives you like if you look flagellated is a giveaway word there. Flagellated and a truth result. Now from also stream, most times it's from mountain hiking is giardiasis. We also look at it, said evaluation shows the presence of antibodies directed against the pathogen. So antibodies, the now says secretion of these antibodies most likely requires binding of which one. So whenever you see presence of antibodies or antibodies released, think of B cells. B cells are also AP cells like Dr. Babawale said, but they cannot function optimally for that antibody. The only antibody they will produce when they're activated is IgM. CD40 interaction with the other antibodies, the other isotopes will not be produced. So if you're able to recognize, okay, this most like giardiasis and is an intestinal parasite, intestinal organism, what protects against all those gut is IgA. So where is IgA going to come from? So if there is no isotype switching, you won't have IgA, you won't have IgD and the other ones. So because you don't have this, B cell has to be activated again by this interaction to give you the antibodies. It's just a summary. So B cells, they present antigens to T cells, they get activated, produce IgM, they stop there. But to produce all those isotype switching that carry out that special asthma cells, it is CD40 interaction. If it's not there, they can't go further. Just simply, just the summary.
Thank you.
You can see you see this 40 in other APCs, but most likely is being related to B cell. Most of the time, it's on these APCs.
Thank you.
Yeah.
Hello. I also think I wanted to add something. Sorry.
Dr. Zulia,
I think that's
yeah, no, so I can correct the idea in my head if wrong. So, because I know that when we're talking about the parasitic infection, what's it called? I remember Dr. Festus saying that for the parasite to even come and engulf or do anything, the pathogen has to be coated with antibodies like IgG and IgA. So, is it possible that it's probably that idea of coating that pathogen first with antibodies before the snowfield?
Yeah, you can kill off
Excuse
those
me,
guys by what
snowfield
we
come
call
in to kill that one.
there's something we call
the antibody
antibody
that we
dependent cellular cytotoxicity.
Yeah.
Hello.
Hello, I'm with you.
Yeah.
So I'm saying that is that the reason why we need that antibody there? Could that be the reason, or is it another pathway entirely or something?
It's one of the reasons. See, the thing is, we should not mix this thing up. This particular one that we are looking at is giardiasis. That is why it's kind of going through this pathway. Giardiasis needs IgA to remove it. Someone that is IgA deficient is predisposed to giardiasis because IgA helps to remove giardiasis. By the time we are doing IgA deficiency now, as we are going downward, during the course of these lectures, we are going to, appreciate that fact more. But ideally, you can take care of your parasite with your eosinophils. I know that just like Dr. Robert now has mentioned, he was thinking of eosinophils. Your eosinophils can still help you take out those parasites through antibody-dependent cytotoxicity. So okay, for example, now once your eosinophils get activated, they can bind to IgG. Do you get it? Your IgG is already complex to the pathogen. Let's say that the parasite we are talking about is like let me use another parasite, maybe Cyclospora. The antigens on this Cyclospora will get coupled to the IgG. The IgG, IgG has Fc region, the constant region. That constant region can bind to eosinophils. So from there, your eosinophils will activate your IgG and they will mop out your parasite. That's antibody-dependent cell-mediated cytotoxicity. Do you get that, Doctor? So eosinophils can do that. Your natural killer cells can do it. Hello?
Dr. Zuniant.
Yes. Hello. Yes. Yes. I was muted. Yeah. I think I got that.
So this is what we are talking about here. So Dr. Toby, this is the antigen.
Yeah.
The antigen is being presented on the MAT2. They get presented to the T cell receptor on the T cell. You can see. Then there's another signal again, which is for proliferation and survival. That's your B7 and your CD28 on your cell. That one is just to activate your T cell. Do you get it? So the end result of that is to activate the T cell. Now, you can see that we are looking at the activated T cells again. What the activated T cell is trying to achieve is to stimulate the B cell so that they can differentiate into the antibody that we need to take care of anything that is causing the problem, the antigen. Now, how do you achieve that? There's interaction between the CD40L of the T cell and the CD40 of the B cell. You can see that. You can see the interaction.
Yeah.
So that will make the B cell activated and it can produce whatever antibodies that we want it to produce. You can see that the B cell is even taking a chunk of the antigen. You can see that it's still taking it. You can see the antigen here. So presenting it to the T cell too, because the B cell is also an antigen, presenting cell. So it can present the antigen to the T cell.
I think that's where it's confusing my head. So the B cell itself can be the one activating the T cell, and also the T cell will now in turn get it to now differentiate into a particular antibody that we require. Thank you very much.
Yeah, you're welcome. Okay.
Then in the option D, there is one option D. CD28 to B7.
Yeah, so that's the co-stimulatory signal that we've talked about. That's one I've showed you. This is
okay. Where the activated T cell, the antigen presenting cell is activating the T cell.
Yeah, that's the second, signal. You call it the co-stimulatory signal. So it's just reinforcing what you are having initially, which is your MAT2 with your T cell receptor. So there's another interaction like that you call your co-stimulatory signal, between your B7 on your antigen presenting cell and your CD28 on your T cell. So that is just active. All of them are working together to activate your T cell. Do you get it? So those are activation. They are not the ones involved in class switching. The class switching is below. You can see the one that is below. That's CD40L. So that's what is now making the B cell produce the antibody. Okay.
I get it now. Thank you very much.
So, Dr. Olatobe, how you say? Yeah.
So, every cytokines is involved in the recruitment of the primary cell type found in this liquid. A 23-year-old man comes to the physician because of progressive pain, red swelling of his left forearm. The symptoms began after his arm on a metal table physics. Examination of the left arm shows a 2 cm thin erythematous fluctuant lesion at the site of the trauma. Extraction and drainage of the lesion is performed, and a small amount of thick white liquid is expressed. Okay, so that's pus, Abi. So what is calling? So we are looking for something that attracted the neutrophils to that place.
That is it.
So
that's a very good one. So which one do you think?
Two. Is it 8 or 2?
No,
8.
It's not 2.
8.
It's
8.
So 8
is
stimulates the neutrophil. You also have another one that stimulates the neutrophils. What else?
LTB4 5H.
Which one?
5H.
No. You guys are saying no. Aside all those ones. You guys are leaving
Applying chemical.
hematology stuff for me. Let's just focus with the one we have learned in immunology for now. Don't be listing ET, all these stuff. I know what you guys are listing. Yeah, you guys are correct, but you know, there's another one in immunology
I
now.
don't know what. Is it
You guys are giving me
the
over syllabus now. Interleukin 8.
Dr. Babale, interleukin 1.
5A.
No.
LTB for
You guys don't get what I'm saying. Specific for
What are you
neutrophils.
No,
asking?
Specific
is it
for
the
neutrophils.
upper TH17 that is secreting this
No,
thing?
you have mentioned interleukin 8. There's another cytokine again. Aside all those N for me methionine that you guys are
Neutrophil
mentioning.
chemostatic.
So which one is that?
Interleukin
That is
5A.
5A, 5A, 5A. That's it.
yeah.
5A. So I know the ones you
interleukin
guys are
5A.
listing.
Is it
I,
interleukin 5A or C5A?
I know C5A,
Is
yeah.
it interleukin 5A or C5A?
No,
Is
there's nothing
C5A?
like
So I was
interleukin
like,
5. No,
yeah,
somebody said
C5.
5A now.
Okay.
Somebody said 5A. So
C5.
5A, that's what you're saying.
Is
C5A. That's what we are saying. Everybody knows there's nothing like interleukin 5A now. Yeah.
Please, what's the answer?
This
No,
immunology, I don't know before from the ground.
see,
it?
this is it. This is it. The question I'm asking is that which of the following interleukins can attract neutrophils aside interleukin 8? And someone said C5A. That is it. Hmm? So
Okay,
C5A
okay,
alongside
okay.
with C4A, C3A, they are what do we call them?
Early,
No.
yeah, anaphylactic
Exactly. Exactly.
Toxin.
Exactly.
complements.
Yeah. So, but C5A, in addition to being an aflatoxin, it can also stimulate neutrophils recruitment. So, so that is that. Um, Dr. Chidima, Dr. Chidima, is Dr. Chidima there? Okay, Dr. Francois.
Yeah, Dr. Valley. Okay. Which of the following is the most likely underlying mechanism for a recurrent infections? 1 week after starting amoxicillin for sinusitis, a 4-year-old girl is brought to the ED with fever, rash, and myalgia. She has been hospitalized multiple times for recurrent strep pneumonia and meningitis. She appears tired. Examination shows a diffuse urticarial rash. Okay, her antibiotic is discontinued. Which of the following is the most line mechanism for her recurrent infection? So she's been hospitalized multiple times for recurrent strep pneumonia and meningitis, and we are thinking of infections with encapsulated organisms.
Mm-hmm.
So then it should be a defective membrane attack complex because that's what's needed for fighting the Syria and the other
What
encapsulated.
about
It's
opsonization?
not.
Is E?
No,
Is E?
Dr.
Recurrent pneumonia,
Dr.
recurrent
Francois.
pneumonia and
It's not meningitis
Eruption
exactly.
too much.
So, um, Dr. Francois, this is this
Yeah,
is
Dr.
not this
William,
is not
please.
Neisseria infection. So this is
Okay.
streptococcal pneumonia and meningitis. So it means that
Mm-hmm.
streptococcal is the one implicated in causing both the pneumonia and meningitis. So if we are looking
Mm-hmm.
at Neisseria meningitis now or Neisseria infection, you can be thinking of
Mm-hmm.
problem with membrane attack complex. But
Mm-hmm.
this is not Neisseria. So you have to
Okay.
look elsewhere. You have to look elsewhere. So somebody having you know recurrent streptococcal pneumonia infection from Streptococcus pneumoniae. So what do you think?
Mm-hmm. Strep pneumonia.
Strep pneumo.
But isn't strep pneumonia also encapsulated.
Yeah, we did not mention the encapsulated one for the membrane attack complex. We said it's only Neisseria. It's only Neisseria that we mentioned.
Okay. I thought it was Neisseria and other
No, we mentioned the
encapsulated.
encapsulated one when we're talking about the early complement, C1 to C4. That was when we were saying the encapsulated one majorly, C1 to C4,
Okay.
the early complement. But for the late complement, C5 to C9, you are only worried about Neisseria.
It's just Neisseria. Okay.
So what do you
So for strep pneumo,
So like what condition do we normally say that okay when there's that condition they are predisposed to developing infection from encapsulated organism, like in people have that
autosplenectomy.
yeah, so people that have problem with the spleen, maybe a form of disease pending. So what will absence of that spleen cause? Look at the options and see the one that fits.
Okay, so that should be the impaired opsonization.
Exactly. So they cannot opsonize. There's no
Right.
IgM again. There's no C3b. So there's no way they can opsonize and take care of those encapsulated organisms. So you must always have that at the back of your mind when you are dealing with. Remember that C3b is one of those opsonins. C3b is one of them. So that is why people with early complement, particularly the C3b one, if it's defective, you cannot opsonize, and the person will be having infection with the encapsulated organisms a lot. So once you see membrane attack complex, C5 to C9, any one of them, Neisseria. So that is it.
Okay, so I kind of get it, but I still don't get it fully.
Okay. Why don't you get it? So what
So so we are saying that this patient has had recurrent strep pneumo infections. And that's the most likely underlying. So are we saying that there's a C3b is like defective or deficient?
This is it. Anybody with problem with the early complement, C1 to C4, will have increased chance of developing the recurrent infection from the encapsulated organism. One of them is strep pneumonia. But there are so many ways you can have. There are so many ways you can have deficiency of those complements. One of them is maybe somebody that has an absent spleen, or maybe the spleen is there but is not functioning. Let's say that this person has sickle cell anemia. That's why they're asking us. Most likely, we cannot guess from this history because we don't have any clean chart to tell us the reason. But they're just asking us which of the following option, which one can explain it. One of the explanation is okay, this person has undergone splenectomy, or the person has autosplenectomy from recurrent splenic infarction from sickle cell crisis. The spleens are not working. If the spleen is not working, one of the function of the spleen is to release IgM, stored IgM, memory IgM. You release them. So the IgM will help you to activate because the IgM can form complexes. IgM can combine with any of the antigen of the bacteria or anything to form complex. And remember the pathway of the classic activation pathway. The classic one tends to activate C1, C2, C4, then down to C3. That's like we are talking about the early complement. You get? So now you don't have all that because there's no way you can, you cannot release any IgM. There's no way you can form complex, with the antigen. So there's no way you can activate your C1. There's no way your C1 can activate C2 and C4. There's no way you can produce C3. So at the end of the day, C3 is defective in them. I know that C3, we said it is a very, very important opsonin. So if your C3 is defective, you cannot opsonize those antigen, you cannot phagocytose them, and you cannot eradicate them. So it means that the organism just in circulation. And so there are so many mechanisms to it. But the final common pathway is that the early complement, particularly most importantly, C3, is defective.
Okay.
And
I get it.
All right.
Thank you.
You are welcome, Dr. Francois. So, Dr. Zuliat, you have not spoken.
Yeah. Okay.
Which of the following medications is the most likely directly responsible for the described change? Okay. So this is a 12-year-old girl who is brought to the physician by her mother 2 hours after cutting her hand while playing in the yard. Examination of the right hand shows 2 cm laceration of the thinner regions of the palm with some surrounding tenderness and erythema. The right palm appears mildly swollen in comparison to the left. In response to this patient's injury, the endothelial cells lining the blood vessels of the affected will express increased numbers of cellular adhesion molecules. So cellular adhesion molecules. Okay, so first of all, that she lacerating her hands and all of that, the next thing that would probably happen would be inflammation. So for inflammation to take place, I think there will be release of the neutrophils and the like, which is making me want to tend towards interleukin 8. However, the addition molecules, increased numbers of cellular addition molecules. I think, that's all those ICAM and the likes, right?
Stop. That is it. ICAM. Yes. We have not even got into ICAM. Dr. Zuliad is already giving us over syllabus. Okay.
So I know it's between interleukin 1 and interleukin 6, but I don't know which one exactly. I've forgotten.
Interleukin 6.
So I think probably interleukin 6.
Interleukin 6.
Okay, fever or something.
Yeah, the active phase reactant. That's what just interleukin 1 and TNF. Those are the ones that increase the expression of those addition molecules, so that the white blood cells can bind to them and they can escape the blood to go into the tissues. So interleukin 1 or TNF alpha.
Interleukin 1
or TNF alpha.
Interleukin 1.
Those are the ones that can adhere, that can express the that can increase the expression of the addition molecules. Don't forget, and both of them can also cause fever. Both of them can also increase hemotaxis. They can also increase attraction for white blood cells to come to that area. So the way to look at it, both of them cause fever. Both of them cause the white blood cell to come to the site, and they both cause the endothelial cells to express the addition molecule, so that those white blood cells that have traveled down to that site can escape from the blood into the tissues. You get?
Okay.
You know that's the significance of expressing the addition molecule, so that they can adhere to the endothelial wall and do the rolling imagination activities
and get to the point of
and get to
injury.
the point of injury. That is it. Okay.
Please, what's the answer?
Interleukin 1.
Interleukin 1.
Thank you.
So if interleukin 1 is not there, TNF alpha. So is that Dr. Muminat? That's Dr. Muminat, right? Dr. Muminat?
No, it's Dr. Miriam.
Okay, Dr. Miriam. Okay, so this one is for you now, Dr. Miriam.
Okay, a 9-year-old boy who recently emigrated from sub-Saharan Africa is brought to the physician because of a 2-day history of fever, chills, and productive cough. His mother reports that he has had several episodes of painful swelling of his fingers during infancy that resolved with pain medication. His immunization status is unknown. His temperature is 39.8. Examination shows pale conjunctiva and yellow sclera. There are decreased breath and respiratory crack over the left lower lung fields. His hemoglobin concentration is 7 grams per DL. Blood culture grows uptochin sensitive, gram-positive diplococci. A deficiency in which of the following most likely contributed to this patient's infection?
Yeah. So let's all look at this. What do you even think that this guy is having? An African boy with fever, chills, and cough. Okay. But this guy usually have episode of painful swelling of the fingers during infancy, and he has yellowness of the eye and pale conjunctiva. What do you think that is talking about?
Dactylitis, maybe HBSS.
Okay, so this is sickle cell anemia. So we are one step to getting our answer. So So he said the person is not.
Octochin sensitive gram-positive diplococci. Is that a staff?
Yeah, so that's actually strep pneumo, but don't worry yourself about it because you might not
Okay.
know it now. So that's strep pneumo, actually. So, but even if you don't know that organism, so a deficiency of which of the following will have contributed. You know what sickle cell will cause, right? What
Yeah, autosplenectomy.
autosplenectomy. So if there's autosplenectomy, so which of the following stuff do you think?
Um, A or D?
Yeah, so I get the problem now. I know where the stuff is coming from. So yeah, so I know it to be logical to also pick D, but the answer is A. Actually, complement come from the liver.
Okay, yeah, that's true. Yeah. That's A.
So this is bacterial clearance by opsonization. So this person cannot clear the bacteria just by opsonization, just like the process we have talked about. Mm. So because of the sickle cell, you know that they experience. So when you see sickle cell, you are thinking of three major things. Three major. I don't know if I'm sure Dr. Fessels will have mentioned it, Dr. Miriam. So what are the three organisms that people with
3 organisms for what, please?
encapsulated organisms that people with sickle cell are predisposed to developing because of the autosplenectomy?
Um, Encapsulated organisms in general.
Okay. Did he mention any
Okay, people
specific?
with.
Did he mention any
No, he didn't
specific
mention
organism?
anything.
Oh, that's
He
fine.
didn't mention any specific, but people with HBSS, strep pneumo, I think
Okay.
Neisseria, and
Uh-huh.
yes,
You are correct.
yeah,
And Haemophilus type B. Haemophilus
and
influenza.
Haemophilus influenza.
All right.
Okay, thank you.
You are welcome, Dr. Miriam. So, Dr. Precious. Dr. Precious Akinpelu, Dr. AK. Is Dr. Precious there?
The violent good evening. Sorry, I can't read.
Okay. Um, the second Dr. Precious, I don't know if she's still here. Um, okay. Uh, Dr. Dr. Dilly. Dr. Dilly, I don't know if you had a chance.
Please, I'm occupied, Dr. Babawale.
You said? Okay. You are busy? All right.
Yeah.
Okay, so let me go back to Dr. Robert then. Dr. Robert.
Okay. The main question is administration of a drug targeting which of the following mechanisms of action is most appropriate for this patient? A 12-year-old boy is brought to the emergency department by his mother because of progressive shortness of breath, difficulty speaking, and diffuse colicky abdominal pain for the past 3 hours. Yesterday, he underwent a tooth extraction. His father and a paternal uncle have a history of repeated hospitalizations for upper airway and orofacial swelling. The patient takes no medication. His blood pressure is 112 on 62 millimeters mercury. Examination shows edematous swelling of the lips, tongue, arms, and legs. There is no rash. Administration of a drug targeting which of the following mechanisms of action is most appropriate for this patient? Okay, tooth extraction. So this patient most likely is looking like I was going to say angioedema, but
Yeah, why not? This is what you
the swelling. Mm, okay, and then the
uh-huh.
family history, so it should be hereditary.
That's the hereditary angioedema for you. That's the hereditary angioedema for you.
Mm,
So you can see that angioedema is not related to maybe bee sting or any use of any medication. There's no rash. You can see there's no rash. So this is
yeah.
pure angioedema. Okay.
Okay. So, administration of a drug targeting which of the following mechanisms of action is most appropriate for this patient? Antagonist at histamine receptor, agonist at androgen receptor, antagonist at bradykinin receptor, inhibitor of angiotensin converting enzyme, agonist at glucocorticoid receptor, and agonist at alpha beta adrenergic receptors. I'm going to go for antagonist at bradykinin receptor.
Yes, that is very correct.
That's successful.
So do you want to tell us why you are picking that? Just a little statement.
Uh, so it's the effect of bradykinin that's leading to the swelling or the accumulation of fluid in
Okay.
the tissue spaces. So we want
Okay.
to block the effects of bradykinin.
Okay.
But I'm sure there's a deeper explanation, but I'm not
Yeah, no, that's fine.
rationalizing it.
But do you know why the bradykinin is accumulating in them?
Um, I think this is the one where the complements, there's a deficiency of the esterases, and then the complements are activated unopposed, and then there's also a breakdown of excessive bradykinin,
Okay.
I think.
Yeah, exactly. So, you know, this C1 esterase can C1
So
can
there's a deficiency of the inhibitor.
exactly. So it breaks down your higher molecular weight kinogene to bradykinin. So it activates one enzyme that we call kallikrein. So kallikrein breaks down um C1 activate that kallikrein so that kallikrein can break down kinogene to bradykinin. So and that activity of the C1 is kept in check by C1 esterase. So if somebody doesn't have C1 esterase, there's no way they can inhibit the C1. So C1 is just there to continue activating the complement, which is C2, C4. They become low, and it will also be present to activate kallikrein, which will break down kinogene to bradykinin. So bradykinin is there accumulating and doing all those things that you are saying. So that is that. So you want to block the action of that bradykinin. That's why you want to give antagonist against bradykinin receptor. So this is hereditary angioedema for you. C1 esterase inhibitor. So some people say C1 inhibitor or C1 esterase inhibitor is still the same thing. C1 inhibitor, C1 esterase. You share the esterase or the inhibitor that is deficient in them. So there's unopposed activity of C1. C1 is just there activating your C2, your C4, and it's also activating your kallikrein, converting kinogene to bradykinin. So bradykinin is in excess, causing all these angioedema symptoms. So that is that. So let's take this
Does
last
the
one.
preceding tooth extraction have anything to do with it?
Yeah, I don't think so. That one is just to
Mm,
make the story complete. Yeah. So
okay.
that's no
All right.
no. So let's take this last one. So Dr. Kenneth, Dr. Kenneth there. Okay, so Dr. Francois, let's just round up with you then.
Okay, so which of the following proteins is most likely to be produced upon activation of this receptor? A 24-year-old woman comes to the physician for progressively worsening episodes of severe crampy abdominal pain and non-bloody diarrhea for the past 3 years. Examination of the abdomen shows mild distension and generalized tenderness. There is a fistula draining stool in the perianal region. Immunohistochemistry shows dysfunction of the cytosolic nucleotide oligomerization binding domain to NOD2 receptor. In vitro studies show that this receptor is usually involved in activation of the innate immune system in response to certain pathogen-associated pathogens, pumps. Which of the following proteins is most likely to be produced upon activation of this receptor? Pumps, innate immunity. Is it NFKB?
Yeah, so that's NFKB. So one thing is,
Right.
once you activate the toll-like receptors on our innate immune cells, maybe the macrophages, the neutrophils, dendritic, anything, natural killer. So once they recognize that pathogen associated pattern, depending on the organism, the pathogen associated pattern can be LPS, which is our lipopolysaccharide, can be nucleic acid, can be even flagella, depending on what we are looking at. So those patterns can be recognized by the toll-like receptors that are located within the cells of the innate immunity, like the macrophages. And once they recognize those pathogen-associated patterns, like the LPS or the flagella within the microbe, they can stimulate production of NFKB. So this NFKB is like a transcription factor that stimulates the production of almost all the cytokines, interleukin 1, 2, all of them. So that is how our innate immunity work. So they produce cytokines. Our, what's it called? Okay, so the innate immunity works, you guys know that it works by releasing enzyme, lysozyme, C-reactive protein, cytokines, and all that thing. Why our adaptive immunity is just cytokines and the antibodies. Yes, and the antibodies. So this NFKB is very important, that if you want to suppress inflammatory response, just give something that can inhibit NFKB action, and that is the mechanism of action of glucocorticoid. So if you give somebody glucocorticoid, steroid to suppress inflammation, that is what they inhibit. So they suppress production of all the cytokines, and you don't have inflammatory response. So that's another clinical correlate to know regarding NFKB. So it's what the innate immunity innate immune cells release to stimulate production of cytokines, NFKB. Okay. So I guess we are going to stop here then. Maybe when next we meet, we'll continue. So hopefully we'll be moving towards the end of immunology by then. So do you have any question?